So today's lecture is going to be on child psychiatric nursing. Our objectives are that we're going to discuss issues related to psychiatric illnesses in children, look at major areas that need to be included when assessing children. We'll talk a little bit about adolescents, but we'll have another opportunity to do that a little bit more fuller in the lecture to follow this one. We're also going to be looking at developing nursing diagnosis or care needs for your patients, along with interventions related to illness in your children. In addition, we're going to identify developmental tasks that they should be able to do and to see those deviations from the norm, and then evaluate the care that we're going to provide to them. Some important points to remember is that 1 in 5 children have a clinically significant psychiatric disorder that should be treated. Unfortunately, only 20 to 25% of children actually receive treatment, and the goal for the global burden of disease is to navigate and research to determine those things that can instigate the probability of children, one, not receiving care, but also to determine those things that can result in an increase in mental illness. When it comes to care for our children, preschool children face expulsion rates 3 times higher than your kindergarten to 12th grade. African American preschoolers are 3 to 5 times more likely to be expelled, and 50% of the children who are in a welfare system have mental health problems. And when we talk about resilience, going back early in the beginning of the semester, and about child development, stress that a child has to endure during their child development can linger on into their adulthood. Alcohol and drug use is prevalent amongst children with psychiatric illnesses. Many of them start at the age of 8 years old, start to have problems in 8th grade, and there's statistics that says that 41% of individuals within that 8th grade said that they were either had one drink, had gotten drunk. 25% of them said that they was smoking cigarettes, and 16% said that they at one time or another had engaged in marijuana use. When we think about mental illness, majority of the time you start to see those signs and symptoms before the age of 6. They can have emotional, cognitive, or physical development issues that come out in conduct in mental illnesses characterized as conduct disorder or antisocial personality disorder, or your anxiety behavior and mood disorders. It is through early identification and then getting them into treatment that we're able to reduce the risk of them these psychiatric disorders going into their adulthood. Some etiological factors include the fact that there is a genetic component, nature versus nurture, as to the development of that psychiatric illness. There's also some research that says traumatic events have a profound effect on children, resulting in PTSD, or because of the stress, ADHD, and going back to the previous slide, they can have conduct disorder, anxiety disorder, and mood disorder. When we're talking about PTSD, we need to understand that there's a mechanism in our brain that allows us to uses neurotransmitters to help our brains deal with the stress that we have and to help it return back to normal. However, if the stress is prolonged, severe, or repetitive, it can increase these neurotransmitter activities to the point that they're irreversible and results in PTSD. With ADHD, it's a combination of some genetic components along with environment. You will see excessive activity or difficulty in paying attention. Most of the time with family, especially when they're younger, we tolerate it because most of the time we link it to just them being young. However, it can start to interfere, and it will start to interfere with their academic performance and even their ability to maintain relationships. And you may hear families say things like the child was unable to finish what they start. And the other thing is is that they may have difficulty again making friends. And so those are some of the different types of assessment questions that we can ask our child. Other symptoms correlate with the fact that they'll have symptoms that overlap a little bit with anxiety disorder. So they may have things like oppositional defiant disorder, conduct disorder, or anxiety disorder, along with that ADHD. Environmental factors that can lead to ADHD include lead ingestion, prenatal or perinatal complications, socioeconomic factors, genetics, brain dysfunctions based due to a damage to the brain, or research says that for some individuals there really is no single finding that explains what's happening, and other research that says that there's a neurobiological foundation for ADHD. In order for our children to deal with some of the mental illnesses that they have, we have to help them be resilient. So resilience is the ability for an individual to withstand stress. Characteristics: they're active, they're affectionate, they're good-natured, humorous, they can be confident, competent, realistic, flexible, and they're assured of the power within themselves to get things done. They know about their inner resources. And with stress, they can recover quickly. They attempt to master their own stress rather than retreat. In addition, these children that have resilience develop a sense of autonomy. They're able to adapt, especially when they're distanced from family and friends. But there's also some sense of role modeling by the parents that offers them reassurance and encouragement that they can do it. And with that support, they are able to overcome the stress and physical disruption related to stress. When we think of the nursing practice related to caring for a child, it requires that we have a knowledge of child growth and development. And then we organize or create our plan of care based on what they're capable of doing. So in order to do this, we have to start with, like all nurse-client relationships, establishing a closeness and a trusting relationship with the child, helping them handle separation, especially when they have to be away from their parents, and then allowing them to be a part of the decision-making process, letting them know that they at least have a say, even though the parents will make the final decision, including their ideas and thoughts into that, and then negotiating joint decisions and helping them with any interpersonal conflicts that they may have. Helping them deal with frustration is a big part of that, especially if it's an unfavorable event. Helping them celebrate good feelings and experiencing pleasure to realize that you can handle both. We have to help them realize that they have to work for delayed gratification. Everything can't be given to you right when you want it. Help them to learn how to relax and actually play, to engage in cognitive processing of not only words, but things that they see, symbols and images, and then establish some type or sense of direction and purpose for them. When it comes to communication, the first goal, again, is establishing that therapeutic relationship or alliance with not only the child, but also with the parent. If there is information that's being given that's vague or unclear, we need to make sure that we're asking for information. Remember that the child may not respond to communication that's problem-centered. So we have to first start with discussions that are more generalized in nature when it comes to how they live their lives or what goes on in their lives. Cultural differences is something that plays a part no matter how old they are or the development stage. We need to understand what their background is, make sure we're communicating based on their cultural background and their beliefs, and then developing a treatment plan with the family and the child. There are some legal and ethical issues in which we as nurses have to advocate. One is their privacy and confidentiality away from their parents, but also to balance what the child wishes and their interests against what the parents are requesting. Then we have to report if a child has plans to harm themselves or someone else, and we're mandated to report to authorities when we have feelings or information that alludes to that the child may be a victim of sexual or physical abuse. Now, there's another section of children that we need to be mindful of, and that's your emancipated minor. Now, your emancipated minor can be free from parental authority if they are married, if they've joined the military, if they are parenting a child living separate from their parents, and if they're self-supporting. With your emancipated minor, they can not only make contracts for their own health services, but they can also give informed consent and may be seen as adult by law. So making sure that you're up to date with your state laws when it comes to emancipated minors will be very instrumental in your nursing process as you move forward. So now we're getting to the assessment part. Components of that psychiatric assessment includes your family interview. Through that interview, you not only get a definition of what the problems may be, you get an idea of the developmental status of the child, but also the family and what their history is like. You get an idea of if there is some type of history of mental or physical health issues within the family of origin and how the family interacts with one another. In their developmental history, we're looking at their demographics, a description of what the presenting problem might be, what might be causing stress to the family or the home, what their prenatal and neonatal history is like, the first years of their life during those really large milestones where you start to see how well they're going to do, what's their general behavior. When it comes to their sexual behaviors, we can ask them to be more specific, especially when the information that they want to provide to us is generalized. If our gut tells us that there's something going on that may require investigation in a sexual nature, we can ask them to tell us more specifically, what's going on. And some ways that we can do that is like through role play or drawings and things like that. And then we're looking at their past, present personality traits. With their family history, we're looking at all the family members, especially if there's a history of psychiatric diagnosis or if there's psychological, social functioning issues. And a lot of times what we do is going back to what we talked about at the beginning of the semester, using a genogram, a family genogram, to get an idea as to whether or not there may be some future. It allows us as healthcare professionals to say there is a family history that may be around 18. There's family members with schizophrenia. We keep an eye on those things. And by doing that, we create a good support system for the child, but also things that the family will look out for. With stress and trauma, we're going to be asking, whether or not they've had caretaker abuse, whether or not they are a victim of abandonment, neglect, physical, sexual, emotional abuse, if they're from a foster home, and then we're testing them to determine how resilient they are. With this mental status exam, we're going to do a complete one. We're looking at their appearance, their orientation, how they interact, what speech and language is based on their development, their motor abilities based on their development, and their intelligence and memory based on their development. Using cognitive, reading and writing abilities, how they socially relate, what their judgment skill is like, whether or not they have insight based on their age level. We're going to be looking at their development, but again, that social relatedness. Do they have personal boundaries? How does the child view their emotional state or the emotional state of others? And what behavior are they exhibiting when they're separated from their parents? Are they alert? Are there any signs of hallucinations? Or how do they perceive things? What's their level of concrete thinking? Most common psychiatric disorders within our children include ADHD, ADD, attention deficit disorder. They may have difficulty finishing homework. It can cause them to be frustrated and upset. They may have depression, anxiety, conduct disorder. They may even have autism. So now we're going to talk about those. We're going to break those down a little bit. So with ADHD, just make sure that you're referring to your care plan within your book. There are some controversies as to whether or not it's nurture versus nature, but 3 to 5% of children have ADHD, and they are usually on medications. Usually after about 3 years, you may see improvement. However, there's an increased risk of delinquency and substance abuse with our ADHD children, so we really want to keep an eye on them. Implications, it's a long-term process because it can go into their adulthood depending on what the cause is, but majority of the time we give them medications and we use stimulant drug therapy. They can also go through clinical behavioral therapy. With depression, this can be persistent in children, especially after puberty. 14% may have major depression before they're 15 years old. Most important predictor of suicidal behavior happens between the ages of 15 and 24, and it can affect them socially, emotionally, and also in their educational development. Symptoms that we're going to look for are similar to those in adults, with the addition of they'll have irritable moods, they'll fail to make expected weight gains, keep depressive thoughts, and they and have secrets, or we say crying secrets. They may later have on them some bipolar that might come out in them, especially closer towards a teenager after hormones kind of kick in. It can be in combination with anxiety, conduct disorder, and or ADHD when it comes to depression. Suicidal ideation can occur in children as young as 8 years old. It's the third leading cause of death amongst adolescents. Risk factors include depression, sexual abuse, prior suicide ideations or plans, substance abuse. They can be impulsive or aggressive, have impulsive or aggressive behavior, and if they have access to firearms, then it becomes even more of a priority. But if we engage in early identification about at-risk use, then we make better progress in helping them. With anxiety disorder, it's a common sign that you'll see, and it's either anxiety with ADHD or anxiety alone, and it's that it results from that fear of separation from their parents or their homes. It can lead to them refusing to want to engage, especially into school or attending school as they get to the ages of 5 and up. It's hard for them to make those transitions. However, if we can get to it early, we can really help them with treatment. However, if that anxiety persists, it can turn into adult panic disorder. With conduct disorder, this is when a child shows persistent patterns of serious disturbing conduct and antisocial behavior. You see this most likely more in your boys. This is the largest group of psychiatric disorders. It can happen in their early childhood, and you may hear a family member say they're just oppositional, very aggressive or defiant. You will see this early signs of this in primary school years, and then it begins to increase as they move on to puberty. And again, a lot of that has an addition to those hormonal changes that they go through. With conduct disorder, they can have outstanding patterns of violations of their rules, no appreciation for the welfare of others. They have little guilt or remorse about harming anyone, including the family pets. They can be impulsive, engage in bullying behaviors, and if this continues without treatment, 40% of them will have a development into antisocial personality disorders as adults. Treatment includes having parent management therapy, using cognitive problem-solving skills, and getting them anger management therapy. With autism, it's important to understand that 1 in 54 children in the U.S. have a diagnosis of autism. 74.2 million children in the U.S. have it, over 1.3 million children worldwide. 3 to 4 times of them are more likely to be boys and predominantly white. The cause of known is unknown, but it is believed that it is due to brain changes because it's evident on scans. There's early treatment and early recognition and development, and especially when there are multiple children in the home, you will see they try to keep up, especially if one does not have as many significant hurdles that they have to go through in development. Then they'll try to keep up with one another. But you'll see more and more now children within the school system who are identified as having autism. Impairment in autism include communication. Most of that is their social skills as well. They have these overregulated repetitive behavior patterns. They do have an average intelligence, but or higher. And so because of that, they're going to need individualized education and health services, especially because of the social component that goes along with that. Mental health is going to be important for them because they're going through a lot of changes that puts them under stress. And so one of the things that can develop is depression, but they can also have anxiety disorders. Part of our plan, we get into our nursing process. What do we do when we're caring for our patients that are children? One, making sure we're doing an assessment to identify what the needs of the child are, what their strengths are, creating a problem list, and then targeting their symptoms, whether it be inattention, distractibility, anxious behaviors, or aggression. Diagnosis that we'll see is that there can be risk for self-directed violence. They can have low self-esteem. They can have ineffective coping because they don't have the resilience. They can have disturbed thought processes. They can have anxiety, risk for other directed violence, especially with our autistic children, and then readiness for enhanced family processes. When we're planning out their care, we want to make sure that we're including a baseline impairment. And then we're going to be looking at any comorbidity conditions that they may have. Are they on any medications? What are we going to be using? Do they need psychosocial support, whether it be individual or group therapy or family therapy? And do they need ways to help them develop coping skills? Effective coping behavior. When they are dealing with stress, you may see them withdraw from stressful situations or postpone an immediate response, of finding more manageable situations, restructuring their environment, accepting good and bad as part of life. And I think these are more ways that individuals engage in coping behaviors. I'm going to go back to say I'm not, well, I guess it is sure. I wasn't sure at first. But at the end of the day, I was thinking if they withdraw from stressful situations, then they don't have resilience. But I will say when they can acknowledge that a situation is not good for them, then they're able to cope by just saying, you know what, I'm going to alleviate and remove myself from the situation to reduce the stress. I think that's more or less what that first one is about. Then postponing an immediate response says, do I need to respond to the situation? A lot of times children, because they lack the resilience, have this need for immediate gratification. And when it happens, they speak and then they say without going, do I need to postpone this? Is this the right time? Is this the right place? Finding more manageable situations. Okay, so I can't control this situation, but is there another way that I can control it? Is there another way for me to manage the situation so that I can eliminate the stress that I'm having? Sometimes that's just recognizing cues. Restructuring the environment. Sometimes they'll be like, you know what? This is causing me anxiety. Maybe I'll move things around. Maybe I'll redo things. Maybe I'll move myself out and find somewhere else to go. Maybe I need to find a new job. Eventually, over time, if we can help them do that as they get into adulthood, they start doing that. If we can get them to accept it when they're small, that there are going to be good, there are going to be bad, and that we just can't withdraw. And then working towards maintaining a good condition of helping them to make adjustments, but also find security and comfort. Treatment settings where children can be taken care of include outpatient in the home through special education, day treatment, respite care, foster care, group homes, residential treatment centers, and sometimes inpatient. Medications are used to improve their brain functioning. We can use social skills training to improve how they communicate and build relationships. We can use behavioral management to help them with that impulse control. And as when they're younger, we can help parents to use things like timeout for inappropriate behavior. With cognitive therapy, we can use that to help them engage in problem solving and communication. And then with parent education, we can help integrate new behaviors and use the parents to integrate new behaviors and skills into the child's life. Therapeutic play is an effective tool that's normal and fun. You choose an activity that a child can be successful in, that's age appropriate, to help them see what it's like to win, but also see what it's like to lose. And then if you get an opportunity, review the semi-structured interview with the school-age child within your textbook and get an idea what that LIDS assessment tool is. With expressive therapy, this is a technique that's used to allow the child to engage in self-expression and self-awareness through painting, singing, dancing, movement, or even writing. You can use puppets or art to teach them to prepare and how to manage their illness or their stress or the things that they want to express. And then as they get older, and maybe when they're able to communicate, old enough to be able to communicate, they can use peer group participation. With art, we have to assess therapeutic needs for stress reduction. It's necessary. I say it works. We can also use art to help them describe an event or express their feelings or provide information about behavior. Use it to give us information about their behavior and their developmental maturity. With games, that's very helpful with behavior disorders. Allowing them to learn how to have control over the things that they say and they do in their own body, such as using something like Simon Says. Games also help increase their concentration and help with their ability to tolerate frustration. Know that the game must take into consideration the child's developmental age and their anxiety. Finally, the one that we have is storytelling. With storytelling is really good to help your child release stress. It teaches them new coping skills, and it teaches problem-solving skills. And this brings us to the end of our lecture. Stay tuned a little bit when we go into our next lecture that's going to be on adolescence.